All right, this morning we have the pleasure of hearing from Arianne Boylan. She is Assistant Professor of Neurosurgery. She's Chief of Neurosurgery at Mount Sinai Brooklyn, the Mount Sinai Health System. She did her undergraduate work at Wellesley and then her medical degree at Yale. She completed neurosurgery residency at University of Colorado and then an orthopedic spine fellowship in Yale New Haven. And her practice focuses on complex spine. And today she's going to be talking to us about ethics in neurosurgery.
Thank you. I'll share my screen. Can you all see my slides?
Yeah, that's good.
Perfect. So I wanted to chat a little bit today about informed consent in neurosurgery. What prompted this talk is actually starting my practice in Brooklyn and noticing a decided difference in how patients were responding to conversations about surgical intervention, specifically cervical myelopathy, and patients who were symptomatic in this population versus other places where I had trained or worked in the country, and wanted to make sure I was doing my due diligence in providing patients with the most information in the best form possible. So in doing so, I had done some research, some of the more recent literature in neurosurgery and surgery in general, and thought it might be interesting to spark some conversation for the team. So I have no disclosures. So today, to review the history of informed consent, understand patient perception of the consent process, understand informed consent optimization in neurosurgery, and the rights within healthcare for our patients. To do this, I wanted to just talk with a discussion of history of informed consent, limitations for informed consent in neurosurgical patients, optimization of the consent process, the medical legal implications, and then the future of neurosurgical informed consent. So there's actually references back to informed consent, back to medieval times when providers were trying to ensure that they were legally protected for any intervention that they may try to perform. But in the modern era, there were 4 legal cases that really started to prompt informed consent as we know it. The first was a case where a patient had a consent for a right ear procedure and ended up having a left ear procedure once the provider realized that the problem was actually on the contralateral side. And there was a lawsuit that went on because the patient's hearing actually got worse. The second was a patient who was having a hysterectomy for seizures, and were told they were getting seizure treatment, but it was not disclosed it would be a hysterectomy. There was a case of an IND for a foot in which a bone was removed, and the patient had not consented to that. And so interesting that a lot of these have some overlap of references to what could be considered some of our patient population. And in 1957, what really prompted the informed consent document was a case where contrast dye was injected for an angiogram. The patient had bilateral lower extremity paralysis. And so based off of that case, as well as what had happened in the world with the Nuremberg Code, the decision was made to make a more formal document. And so based off of what had happened in World War II, this was what was provided specifically for research, that patients should have sufficient knowledge and comprehension of what was being offered so that they could make an enlightened decision, and they must know the risks and benefits and how that may affect their health and their livelihood going forward. In 1979, in response to the Tuskegee report, the emphasis on comprehension became a bigger part of the dialogue. And so efforts were made to try to figure out how to achieve that for patients. And so again, everyone on this meeting today understands the word, but just the actual act of grasping what material is being provided and having a knowledge or understanding of it. In 1983, there was an article that came out in JAMA that kind of condemned providers, saying that little progress had been made in ensuring that information that we were relaying to patients and their families was comprehensible, understood, and used, and really advising to go against using medical jargon, especially during a consent process. And then in 1986, the AANS came out with their kind of first global statement and their code of ethics regarding informed consent, and specifically wanted to discuss autonomy and get away from the paternalistic consent process that they felt had been previously imposed on patients. They also said specifically, though, that informed consent was never actually feasible for our patient population, and so that this was a conflict between ethical theory and practice, which unfortunately did not help us in the medical legal world. And there have been several attempts at updates in more recent years as well to try to say what is actually necessary for an informed consent. So most of the literature now really wants us to be using the terminology, the process of informed consent, to make sure that we're not just thinking of it as a piece of paper that the patient is signing, but more the document of the conversation we're having with the patient and the family. And in the medical legal world, it seems that that is actually the more important component of the consent, what we're saying that we discussed with them and how we advise them. And that should be including treatment options and alternatives, risks and benefits of all options, recovery time, what recovery would mean with complications that could be expected, for example, in the spine world, a duotomy, and how that may delay hospital discharge, and who would be present during the procedure, more relevant for the academic medical world. So obviously there's a lot of limitations for our patients. We're oftentimes encountering these patients in an emergent situation and don't have the luxury of time to really go through all the various options and to really fully explain the underlying pathology to the patient's family. Cognitive changes from underlying pathology in our patient population, patients who are in severe pain and so may feel that they're unable to fully engage with the conversation or may feel pressured as a result. Families who are trying to honor advanced directives for elderly patients, but struggling to see how those advanced directives may or may not correlate with their loved ones' goals of care and how we can help guide those conversations. And then complex procedures that we perform that can just simply be overwhelming to people who may not have a lot of medical background in what we're offering. So there are several papers out there that look at recall and neurosurgery consent, meaning that when we think we've done the job correctly and spent the time, how many patients are actually understanding what we've said to them. And so in 2020, there was a paper that looked at 104 consecutive patients, and they asked the patients to write down the risks that they recalled after the consent process. The mean age of patients was 52. 52% of the patients were cranial and 48 were spinal. And the risks that were mentioned were numerous. There were 32 risks for cranial procedures and 25 for spinal. And interestingly, after spending, they said 35 to 45 minutes with the patient, the number of risks recalled were 5 for the cranial consents and 4 for the spinal consents. And 65% of patients did not recall more than 2 of 6 major risks for both types of procedures. There was no correlation to age or education. And they did find, however, that emotional state at the time of the consent process and the visit did correlate to recall, and suggested that if we perceive a patient or their family to seem overwhelmed, that we come back at a later date to continue with the consent process. There was another paper that examined 21 articles globally, and the vast majority were in North America, as you can see represented on this map. But 8 were medical legal, 6 were for how to improve the consent process, and 7 were patient limitations to consent. So likewise, like the prior paper, when they were looking at baseline recall, 29% of patients did not recall any of the risks of a neuro-oncology drug. And those who did have some recall a maximum of 4 risks that had been discussed during discussion of a medication and not a procedure. For lumbar spine surgery, 50% of patients remember the word paralysis, and 6.5% of patients recalled the word recurrence. And they specifically linked this to medical legal implications and lawsuits, and that patients were less likely to recall adjacent segment disease or recurrence as things that had been discussed during the consent process, even when documented as such, and were upset when those complications or anticipated things occurred. In the pediatric neurosurgery population, it seems that things were going a little bit better. 98% of patients' representatives understood procedure specifics, 84% remembered majority risks, and 24% remembered alternatives. And the thought process of the large disparity was that if an individual is making a decision on behalf of another, they may have better recall than their own, and there may have been a higher percentage of more than one family member present during the consent process. For capacity for consent, 3.6% of patients with tumors seen in over a 2-year period were found not to have capacity. So despite numerous interactions with the neurosurgical team and talking about the care, a modest percentage of patients were found to actually not have full grasps or capacity of what was being discussed with them. Of this particular population, 77% were high-grade gliomas, and 19% of patients agreed to cognitive testing at the 2-year mark, and 15% were found to not have capacity. For the stroke population, likewise, 80% of patients were found not to have capacity on arrival, which is anticipated, and 60% improved with formal testing 24 to 48 hours after admission and intervention. So obviously, like our patient population, we have family members who are helping to consent, but just a sign that sometimes patients who we know well in the office may be losing their capacity to fully understand what it is we're offering them. Time spent with the patient seems to be one of the most key elements of the consent process. So there was a paper out of UCLA orthopedic surgery in 2001 that talked about major operations, and I'm not bringing this up from a gender perspective, it's just from a differences in provider perspective that in this particular paper, they found that some providers were spending significantly less time than others. And so in 2002, the Orthopedic Academy sought to standardize the consent visit to 45 minutes, which obviously is not always feasible given the time allotted within a medical system or how many patients are needed to be seen in clinic. In 2004, there was a study in Manchester that was in response to doubled lawsuits for specifically the lack of consent from 2012 to 2017. And 68% of patients who had complications were identified. 58 actually participated. The reason for the disparity was more trauma patients who did not have cognitive capacity to participate. The patients ranged from 18 to 84, 26% were employed, 33% retired, 57% female, and 45 had consented for a procedure before. However, only 7% had consented for a neurosurgical procedure before the index operation that was being discussed. 98% of patients felt they had enough time. 80% were offered a family member or friend. 17%, however, felt that despite this, they did not understand the recovery process. And 63% felt that they understood recovery from a complication. So showing that we do seem to sometimes do a better job of explaining the risks and what that can mean, but the standard recovery is not always fully explained to patients in a way that they are grasping. For the providers in that study, excuse me, on average, the surgeons had 3 to 14 years of experience. The average was 6 years. 50% of the providers admitted to not discussing recovery time. 17% gave patients information to take home or had online links for their particular practice for more information for patients. Only 39% gave a copy of the consent to the patient. 0% admitted to ever having read the consent form that they were having the patient sign, and 100% reviewed alternatives. But the main thing all the providers had put in their survey was that they needed more time for the consent process. Likewise, a 2023 patient experience paper out of Istanbul found that out of 276 patients, 65% said they understood the consent form, 92% understood the procedure, but 47% did not feel comfortable with their surgeon. And this had a direct correlation between the amount of time perceived was spent on the consent during the visit. So again, time is really crucial. So when and how to consent beyond just the number of minutes spent is also been discussed quite a bit in the literature. And there's mixed literature out there whether or not patients feel more satisfied signing a consent form on the day of surgery, obviously with a consent conversation and dialogue process happening before that day. But if patients perceive that the majority of that conversation is happening on the day of surgery, they do have a lower satisfaction rate and retention rate of that information, which makes sense. There was a paper out of the UK where patients had been had the surgery discussed in the office before the visit, but signed on the day of. And 98% of those patients felt that they did have enough time. And interestingly, 48% of those consent forms that were signed on the day of were done by a resident. And length of stay was not affected when consent was obtained. And in general, electronic consents, which are mostly used at the VA here, are in general give more patient satisfaction than staff satisfaction, which has many potential correlations, but can be helpful for the whole team to be able to see it quickly. And then who is present in surgery being a part of the consent form. So there was a 2012 paper in JAMA that looked at 316 consecutive patients who were consented for surgery. 91% felt that they were getting better care at an academic center than they would have at a private hospital. 68% felt that their care was improved with the residents being present and they were getting more attention. 85% consented to an intern being present and participating in the surgery, and 94% a more senior resident. However, when those same patients were given scenarios over how much the resident may participate in surgery, those percentages went down dramatically based off of the year and level of training of the resident involved. And so the suggestion off of this was to be transparent about who would be present during surgery, but provide patients reassurance that the attending would be present for all critical aspects of the procedure and be overseen. So again, based off of those prior studies, timing is everything for consent. So really spending more time with the patient and their family and making sure that all their questions are addressed and trying to have them recite back to you what the intended procedure and diagnosis is, which obviously can take more minutes during the office visit and may require more than one visit. So in general, improvements that are suggested out there in the literature, there was a study in 2015 that looked at cervical myelopathy patients who had OPLL, and they found a statistically significant difference in patients who had had 2 or more office visits for part of the consent process, were provided with literature from their surgeon, and guided towards appropriate online resources. So something that with Jillian's hard work in giving us all our surgery packet booklets, that we can be continuing to optimize those for our own patient population. In 2006, Pittsburgh Neurosurgery Department looked at 120 consecutive patients and did specialized consent forms for individual surgery practices. And they found that if they had specific check marks that surgeons hand to click off as part of the consent process and have the patient's initial, that patients had a much better recall. They understood their diagnosis and the intended procedure. They had better recall of alternative treatments that were being offered because that was part of the consent process. 97% recalled all major risks. And 4.5 months later, 100% of patients were able to recall their diagnosis and the procedure that was performed. 72% the alternative options that had been presented before the surgery, and 91% the risks. So patients were retaining better overall. Other things, the surgery booklets, as had been previously mentioned, patients, even with those booklets, had responded, however, that prognosis, follow-up, and how they would be seen in the office and do's and don'ts post-op were not adequately provided in these booklets most often. And the surgeon experienced that they felt they wanted more insight on that so they knew who they were having surgery with. Again, things that I think our team does very well. In 2015, there was a study looking at how patients responded to discussions with visual aids. And in the cranial patient population, this was significantly helpful, that there were significant increase in patient satisfaction with this attempted explanation. However, in the spine world, this may not always be as relevant, which is interesting, at least in the deformity world. Ames had a paper that said only 45% of patients were able to show improved recall with a visual aid. Although all felt the consent process was important, they didn't feel that this added to their experience. So limitations that the literature states we all have to try to overcome, but is more difficult, are interpreter's choice of words, unless we have some baseline understanding of the language that the patient speaks primarily. Oftentimes, word choice can limit a patient's understanding or actually give an opposite interpretation of how we're trying to convey a procedure to the patient. Ways to try to improve this are, again, to have more than one clinic visit so that there's a greater chance of having a separate interpreter and or having a family member or friend who's bilingual to help stop if the wrong word is being mentioned. Excuse me. Also, having written consent forms in a primary language, more difficult in New York, where there are many more primary languages than in other places in the country. And in the spine world, there was mention that we are not as good about revealing if patients are going to have navigation and intraoperative CT scan or fluoro exposure to radiation, and that should be a part of the consent. And then concurrent procedures by anesthesia or urology, which obviously anesthesia is doing their own consent forms, but making sure we also are disclosing to patients that they will be intubated if appropriate. They would have an arterial line, and that a Foley catheter, if appropriate, would be placed, and that can have its own set of complications. So general suggestions in the literature for patients, especially with complex surgeries, to have more than one office visit, be it virtual or in person. Encourage family members and friends and review the patient's own imaging and hypothetical post-op constructs in the world of spine. Provide patients with hands-on booklets that they can take with them, or provide them with online resources. Patient support groups for pre and post-op, and to encourage patients to seek second opinions if we see that they are unsure of how to proceed, and to get to know our patients and their goals of care and cultural diversity, how that plays into what their goals are for their outcome. So with regards to that and patient autonomy, Augustus White, who is an orthopedic surgeon at Harvard, had written a book called Seeing Patients' Unconscious Bias in Healthcare. And really, the main punchlines or takeaways are empathy towards patients and understanding their values and what is a good life, and which may be different than what we perceive for our own, but obviously very relevant in the neurosurgical population and difficult sometimes to obtain in a short conversation in one clinic visit or in an emergency situation. Edmund Pellegrino, who was head of bioethics at Georgetown, had talked about enhancing a patient's decision-making and involvement in their medical care, and to promote their dignity, acknowledging that there are limitations that we may try to overcome in achieving that. And in a trauma, a patient would be unable to give full consent. However, Dr. Pellegrino also had mentioned that while patients may be knowledgeable about their illness, they often do not know the whole story. And so even physicians who become patients, unless this is their specific subspecialty, if a patient or physician-patient is trying to dictate their own care, the provider does have the right to say that if this goes against their clinical judgment, the patient should seek another opinion. And so that also can become a part of that informed consent dialogue. There was a paper by two bioethicists in 2000 that talked about autonomous choices and actions being rational. Some of the examples they were giving were being a Jehovah's Witness in the surgical world and helping guide a patient and their family through what that would mean for a transfusion, acknowledging their beliefs and allowing them to make that decision. And that if the provider is going against what they see as the rational judgment, that could be worse than patient abandonment. So again, offering either a group consensus through a conference within the department or an ethics consult, and or a second opinion from a colleague or from the patient's own choice can be helpful for those situations. And our role, again, to be educating the patient and their family, but ensuring that we're not forcing a decision upon them at any point. There was another patient autonomy article from that same year that specifically spoke about female patients who may be in a marriage where the husband or father is making more of the medical decisions for that patient. This was specifically in regards to fertility, but the recommendations given were what we would all do, that to isolate the patient, make sure that they're fully understanding, offer them resources, but respect their decision and show that it is being acknowledged. So the medical legal implications, the legal standard in many jurisdictions is to provide all information so that an average reasonable individual has the information required to make a decision or pursue or decline a treatment. No limitations on who would provide this, but strongly encouraged that the attending who would be performing the surgery be at least involved in the consent process. And that the greatest source of, in the spine world, lawsuits are failure to diagnose, treat technical error, and failure to adequately explain complications that could happen during the procedure. Limitations are that most of those studies reflect the spine population and not the cranial population. So for the future ideas, continuing as a department to work on neurosurgery preoperative video or interactive online courses that some of our other hospitals in the city do offer to patients. Continuing with pathology or surgery-based education online and pamphlets that several of our practices use. Evaluation of whether or not our patients are finding this to be helpful, and surgeon or section-based consent forms based off of some subsequent data that has come out of other institutions that shows that patient satisfaction and retention is improved with this. So opening it up to suggestions or ideas from how my colleagues handle these situations as well.
Thanks a lot, Arianne. Great question slide. That's hilarious. Such a pertinent topic. It seems like I was really interested. You said that in one study, 0% of the patients read the consent, and only like 20-something% got a copy of the consent at any point. So it seems like the consent process that we currently use and the document that we produce from that is basically a legal document and not really a patient-focused document if they're, essentially not reading it and not getting it. It seems like an area kind of ripe for reform.
100%. And kind of concerning that vast majority of the providers also had not read the form that they were having the patients sign to.
Any questions from anybody?
I had a quick question. Just as someone who's now doing more consents for anything from small procedures to big surgeries, we always talk about the big risks of surgeries. And I always say, these are things we don't expect to happen, but I include, paralysis and things like you mentioned that patients really seem to remember. And I just wonder for more high risk cases, when you do expect there to be some kind of deficit when the patient wakes up, what's the best way to prepare them for that during the consent process?
I definitely open it up to people who have more experience than myself as well, but I personally try to explain to patients how when there's, from the spine perspective, compression that has been present for some time, it'll take up to 1 to 2 years to see the full benefit, and that sometimes as something that's been very compressed is released, it will swell, and that can cause new symptoms such as weakness or numbness that oftentimes are transient but can be permanent. And that's one of the reasons that we use neuromonitoring during surgery to help objectively see those changes that are happening during surgery so that we can intervene and protect them the best possible.
Thank you.
I had another question, Dr. Boylan. I think sometimes, from my experience, we're explaining a lot of procedures that are complex, and sometimes, like from the perspective of a physician, it can be hard to explain these surgeries in a more simple way. Was there anything in the literature about using like more simple language for patients to understand the types of procedures that we do?
100%. The official guidelines from JAMA and the AANS both say specifically that we should be using no medical jargon and using plain English to describe the procedure, but also the diagnosis itself. And that for our residents who are helping participate in the consent process, making sure that they have involvement either in the office or at the bedside with hearing and attending do the consent talk for a specific procedure a few times so that it's a shared process for how we can better improve it.
Dr. Boylan, just I'm wondering if there's any studies looking at when multiple teams are involved in a surgery. For example, like our spine team works with plastics a lot, our skull-based team work with ENT surgeons a lot. So does that complicate the process and reduce patients' understanding, or does that help? Is there anything looking at that?
I did look for that. I personally didn't find it. I also was looking for years of surgical experience and time spent during a consent and things of that nature, and was unable to find that in the literature yet. But I think a very valid, important point, and something maybe that you can help put into the literature so that we can do a better job of it when it's a multi-team approach.
Dr. Boylan, I have a comment. Most of the literature that says to avoid medical jargon, I think it's from many years ago, where when the patients did not have access to medical records. I have found actually that many patients are asking me, "Oh, what is spondylolisthesis? What is stenosis?" I saw that in the MRI report, and actually they asked me to explain. So usually, I use the terms and explain them preemptively, and they like that, and I think it has to do with the access to the medical records. That is something more recent.
100%. I think we definitely need to explain everything that's written in a radiologist report, but to actually put it into context, either visually or verbally, into an analogy that the patient has a grasp of. 100%.
All right, and Dr. Proskov has a question in the chat. Can you see that?
One sec.
Is it better to be more global in writing down and in discussing risks versus benefits during informed consent, or to be very specific? If a complication encountered is not one that was discussed, are you more medical legally liable?
That I don't feel that I can necessarily answer intelligently, given lack of medical legal background. But from what I was reading in the literature, to be documenting a very thorough consent, and always say another possible complication, so that one is open to things that one could not anticipate, but go through things that are the most likely to occur, and that as long as it's documented in a note, covers a person as far as what can be reasonably expected.
Thank you.
Ari, I just want to say I thought that was a great topic and a great talk. And I had a question for you. I saw two surgeons when I was in fellowship who had a checklist, and they had the patient initial next to it. I acknowledge I am at risk of death and pseudoarthrosis and permanent nerve injury and this, and they put their initials next to 8 or 9 things. Maybe the most commonly sued items, I'm not sure. They were very seasoned surgeons. So my question to you is, does that actually protect the surgeon more than our traditional consent? Do you know?
I don't know for sure legally, but from what I understood from the literature, it's not necessarily about the legal protection on the consent form. Our notes and documentation protect us much more than the thing the patient signs, because that reflects the dialogue that we had. However, the studies show that surgeons who use the patient-specific forms and have them initial by specific risks are more likely to spend more time going through that form and specifically commenting on alternative therapies and risks and benefits of the alternate therapies versus surgery. So it's maybe more of a checklist for the surgeon to have not forgotten any part of that conversation or dialogue, which does protect us more.
Yeah, and I guess part 2 to my question is, like, because I'm a little sick of giving my ACDF risk talk. It's like the same talk to 10 patients a day, and it takes a long time. And so I thought about making a YouTube video or some video, show the patients, leave the room, come back and say, do you have any questions? Do you feel like is that something you came across in any of your review?
They definitely said using the online resources or booklets as supplemental material, but that patients really wanted that FaceTime, face-to-face with the attending surgeon. So even though we kind of just press play on our script that we're saying in our head and hope we don't forget any words, that they really did appreciate that face-to-face time. But likewise, when I first came here, I was starting to try to work on a kind of spine school video, which I keep starting and stopping, just we all need more hours and minutes in the day. And I think it could be really cool if we all join forces on that for our patient experience so that maybe we limit the number of visits and have that be in lieu of having a third or fourth consent visit, where patients can engage in that and have some of those more common questions answered.
Yeah, I was thinking the same thing, Jeremy. I'm wondering if anybody here does that. Does anybody have a video that they show the patient and then kind of have follow-up questions?
We have a handout that the team has made, and they all get a packet. But I agree with Arianne, and I'll just point out that the title of her talk had more to do with ethics than legal, and so I think she was focused a little bit more on trying to enhance communication. My unfortunate experience with the lawyers has been, it is echoed really nicely with what you said, Arianne, that the body of the documentation, the body of the note, is more important than the consent form. However, it is certainly possible that the patient will, if they're involved in a legal proceeding, will just tell you that either that conversation that you've documented didn't happen or they don't remember it.
Yeah.
So,
Can I say something?
sure.
Yeah, we had a video on ABMs that we gave to the parents, but actually we gave it in the first visit so that the patient actually took that video with them in the first visit. And when they came back, they actually were much more educated about it. And we did document that a video was given to the patient so that if they tell you, I don't remember, but you had a video. And did you watch it? So I think the idea of doing a video for consent is a good one.
Great talk.
Yeah, I still see some issues with the video because then the lawyers can say, which video was that? Was the same as the patient show. I heard of a case that it was documented the risk for infection, but the whole argument was that the patient was not informed about an increased risk for infection because had diabetes. So these games that lawyers can play. Sometimes you cannot really predict every aspect of it.
Well, not necessarily, but you document the video. The video is documented, and you play the video. If you were in court, you actually says this is the video. You play it so that the jury, you make the video that is understandable to the layperson. I think there's no harm. Let's put it that way.
This just reemphasizes the importance of communication.
Right.
The other observation that I would make is that there are certain doctors who spend a lot of time with their patients, and they're known as good communicators. And those are the doctors who are less likely to have conflict with their patients, whether it's medical, legal, or any other kind. One of the best doctors I ever met in this regard was Cal Post. A really great communicator with his patients. But that didn't, keep him out of the lawyer's office from time to time. A whole separate issue for grand rounds is medical legal discussions. Neurosurgery is among the fields that has the most medical legal activity. Almost 100% of physicians are sued. Many, so it does happen, neurosurgical physicians. It's a whole separate discussion, and I like what Arianne was focused on, which is how to enhance communication. Thank you.
We had a lawyer for grand rounds maybe like 6 or 7 years ago. I don't know if anybody remembers that, but I thought that was really helpful. Maybe we could get that person back.
Yeah, we can get her back. We have a person at Sinai who is not actually a lawyer, but she is the one who sort of oversees most of the medical legal activities. We, of course, have lots of lawyers, but we can bring her back. That's a good idea, Chris.
Can I make? I remember that lawyer was a very tall guy 6 or 7 years ago down in the 5th floor room.
Yeah.
And my concern there was that he presented a lot of things that were prohibitively difficult for us to do in the time that we had with the patient under any circumstance. So the emphasis has to be on a practical solution to these medical legal concerns.
Yeah. That lawyer is now, has since retired, and he's like deep sea fishing off the coast of Montauk somewhere. But Bonnie Portnoy is still with us, and we'll bring her back. She's very, very practical. She will emphasize documentation. Documentation.
Can I make one?
Consent form. Yeah.
Can I make one quick suggestion? My experience is that the number one predictor of a patient suing for malpractice is a prior experience suing either somebody else for malpractice or suing somebody else for fault or negligence. So if you see a patient who has a history of suing somebody else, that's the time you really need to up your game on your documentation, just to protect yourself. You know, it won't protect you from being sued, but it may protect you from losing that suit.
Okay, I can see there's an appetite to discuss lawsuits here. Maybe we'll revisit this another time.
All right. Thanks a lot, Eric.